Well, welcome everybody in person, and I see we've got a good crowd virtually, so nice for everybody to be here. It's my pleasure to introduce our Grand Rounds. I'm going to call you our traditional December Grand Round speaker. This is our diabetes technology session. Erin Newkirk, as many of you, if not all of you know, is one of our pharmacists here. She received her PharmD at UW and did a residency in ambulatory care at the Middleton VA in Madison, and is, I don't want to get this wrong, the Wisconsin coordinating body leader for the the Association of Diabetes Care and Education Specialists, even though I murdered that. So an important group, and you are really vital to their work here in Wisconsin. On a personal note, so much help that Erin provides for all of our patients with diabetes. And we'll be excited to talk about volleyball games coming up here as the volleyball tournament starts for NCAA. So, all yours.
All right. Well, thank you everyone for being here in person, and anyone that's on virtually as well. I'm always super passionate about talking about diabetes technology, so I appreciate having the opportunity to speak to all of you. So I was initially thinking, because I kind of bring new technology to each year, and we have a lot of updates, so I'm going to present a lot of updates and focus a little bit on a new pump called the Twist pump, but it's not available yet. It is cleared by the FDA, so that will be kind of our new information that we'll go over as well. So, all right, so just kind of giving some updates, kind of summarize some of the automated insulin delivery differences between the pumps and how to kind of optimize those settings. Talk about the new Twist automated insulin delivery system. If you didn't notice and you're interested in participating in using the simulator apps during the presentation, we'll go over some cases and kind of some button pushing so that people can really familiarize yourself with the apps and what patients experience with button pushing on their pumps, as well as if you're ever helping them on a phone call and trying to navigate what buttons to push if you don't have that memorized. That can be kind of helpful. And then we'll do a break off, and Allison will work with all the virtual people, and then we'll go over some cases here in person as well. All right, so I don't have any disclosures. Just starting with American Diabetes Association Standards of Care related to technology, 7.1 says diabetes devices should be offered to people with diabetes. And essentially it doesn't specify the type. So I think that's a really important point. And then 7.5 really focuses on highlighting the use of our educators. We have a great educator team, and of course it's so important when patients are initiating new devices, but then of course ongoing training, because things change in people's lives and they need adjustments and different training for different scenarios. So, all right, so here's the CGM. I have added prescription personal CGMs since we now have over-the-counter. So we have the Abbott Freestyle Libre systems, Dexcom, Medtronic, and then Eversense. And then in terms of the professional CGMs that are available, it's the Freestyle Libre Pro and Dexcom G6 Pro. So we'll go into these in a little bit more detail. So the Libre, the newest versions are the Plus. So we have the Libre 2 Plus and Libre 3 Plus. Both of them are 15-day wear. There's less of an interaction with vitamin C. Patients can take up to 1,000 units. They start the sensor by scanning, but then they don't have to. It's no longer an intermittent scan device. It's a real time after that point. If someone is upgrading from a Libre 2 to a Libre 2 Plus, they do need a new prescription. But if they're using the reader, they would just still use that. If they're on a Libre 2 and they go to the 2 Plus, that reader will work for either one. But both of the systems only work with one device at a time. And so that's kind of important to know, because some patients could be used to, with like the Dexcom, they can use the app plus the pump or different things. So, and then the Libre 2 Plus works with the T-Slim, Control-IQ, and then Omnipod 5 is brand new, just within the last few weeks, being compatible. And the Libre 3 Plus is compatible with the iLet. Dexcom, one of the bigger, newer things is that it has direct to Apple Watch, which really, this is helpful for those people that maybe want to exercise and not bring their phone with. They still actually need their phone for initial pairing and the share feature to work. But then after that, essentially they could essentially use their watch to get their data and get alerts, which is nice. G6, they still have to have the smartphone nearby. One of the recent changes with G7 from kind of a practical standpoint in clinic, because I think sometimes we're struggling to get the data that we need, is historically people would have to have the Dexcom G7 app and the Clarity app. Now people that have Dexcom G7 actually can go to the button here, connections, and then it'll link in, you can pick Clarity Clinic, and then essentially our code for our Freighter Clinic is diabetes, with the I being a number 1, and so then you can confirm. So I find a lot of patients forget their username and password, and so they have their G7 running, but then we try to hook them up to Clarity, and it's a nightmare. So this is a really nice, I think, feature. And then one of the new announcements just last month was that Dexcom has a partnership with the Aurora Smart Ring. Does anyone here or on virtually have one of these rings? I have a friend that's son won one or something, but he thinks it's the best thing ever. But anyways, it can detect lots of different things. So it'll be exciting to see kind of how this all plays into continuous glucose monitoring in the future. And then moving on to Medtronic, their newest sensor that's a standalone sensor that's been approved is called Simplera. This is finally catching up to our Dexcom and Libre. You can see visually it's disposable. There's not a lot of over tape. The applicator is kind of similar almost to the Libre. It's FDA approved initially right now just for 18 years and older. And then the whole thing, as I said, gets thrown away. The smartphone is the display device. There's no calibrations. It's worn for 7 days. And then they just, within the last couple of weeks, got clearance with their in-pen connectivity. And I think, I don't know all the details yet, but there's going to be some more kind of like guidance to the patient if they miss doses and what to do to correct and some of those things with this new connection. And then what we're waiting for is the Simplera Sync to be FDA cleared for work with the Medtronic pumps. And I think that's going to be a huge game changer to have the Medtronic pump kind of back in options, because I feel like their sensor's been unfortunately a little bit behind, and it's a choice that people tend not to make just because it's not quite as easy. So once they get the Simplera Sync, I think that will be great. All right, moving on to Eversense. So one of the more recent approvals for Eversense is the clearance for a 365-day wear, which I think that makes a difference. It used to just be approved for 180 days. And so this is the sensor that's implanted under the skin on the back of the arm. It does still require calibration daily for the first 13 days and then weekly after that. The only display device is the smartphone. There are on-body vibrations. Some of that, I think, where this plays a role, I just don't feel like this is definitely for everyone. It's probably honestly a smaller group that would be interested. Hopefully, sooner than later, maybe we'd have one of you interested in inserting these for our patients. But some of the benefits is thinking about is that it's a one day. I know a lot of people struggle with the first day because the sensor accuracy is a little bit decreased. There's also a warm-up period. So essentially when you have wear it or have it implanted for 365 days, there's only day one. There's also people that have a lot of skin issues with some of our sensors, so it's silicone-based versus acrylic, so that's a nice option. There's some data that shows better accuracy in the lower glucose range as well, and then there's no concern with compression lows, which some of our patients experience with the other sensors. A couple other kind of counseling pearls. One of the recent updates with Freestyle Libre 2, 3, and both of the Plus versions is that can now be worn with X-rays, CT scans, and MRIs. So that I feel like makes a big difference. I feel like that's come out just even the patients I've seen this week that are currently undergoing like chemotherapy or a lot of scans, where if we're deciding between Dexcom and Libre, with this approval, I just feel like it's a no-brainer to help them decide if they're interested to go to the Libre route, just because that interruption and lack of supply because they have to take it off early is a hassle. Eversense can be worn during MRI and imaging. The transmitter would have to be taken off. And at this time, we don't have any clearance for Dexcom or Medtronic sensors with any of the imaging. All the different CGM companies do have sharing apps. So I think that's really helpful for some of our patients to have that set up. All right. In terms of coverage, this is continuing to expand every year, which has been great. Some of the highlights with Medicare is that it's approved with type 2 diabetes and they can be on any type of insulin. So even those inhaled insulin patients could essentially get approval. And then the big thing that's tricky and of course frustrating is that Medicare doesn't look as a smartphone as a medical device. So it requires patients to receive a reader, but yet they only cover a reader once every 5 years. So as we're upgrading, I saw someone this morning that was still on a Libre 14-day and had Medicare. And so they then would have to pay out of pocket to get that updated reader, which, I mean, especially, I don't see anyone on 14-day Libres anymore, but she definitely needed alerts to be going off. So it's worth moving that direction, but it's frustrating, you know, for patients. Medicaid, as of October of 2024 in Wisconsin, included now any type of diabetes, removed the age requirement. It used to be 21. And then they have to just be on insulin, check their glucose frequently, or at risk for hypoglycemia. So that's been much improved compared to previous coverage. Moving on to over-the-counter CGM, the Dexcom Stelo has been approved. So this is for our type 2 patient population that are not, or prediabetes that are not on insulin. It does not have any alerts or alarms, but for the most part, you can see it kind of looks like the Dexcom G7. It's a 15-day wear, so the timeline is different, but really the goal is to help people really look at their lifestyle and how that's impacting their glucose and overall health. Right now, it's only sold through the Dexcom website, and but the data could be viewed on Clarity. And then the Abbott, they have two different products. Only Lingo is on the market right now, and those are for patients without diabetes, so it's more of a focus on their metabolic health. And there's no opportunities for patients to share their data with us, so you'd have to just look on their app to see the information. And there's no alarms, worn for 14 days, and that's also sold through their site. And then the Libre Rio, is not available yet, but that's going to be targeting the type 2 patients who aren't on insulin. So kind of moving into automated insulin delivery, just to kind of set the basic stage for this. So the components of automated insulin delivery include the continuous glucose monitor, the insulin pump using rapid-acting insulin, and then kind of the brain or that algorithm that connects the devices. And so the main function is adjusting insulin. All the systems adjust basal based on glucose prediction and trends, and then some of the systems also additionally give auto corrections. For the most part, patients should be either able to carb count or be carb aware, and then they need to know how to adjust for activity in kind of daily life. In terms of the ADA guidelines, it's recommended to offer to youth and adult with type 1 diabetes, as well as consider at diagnosis. There's some consensus guidelines that really kind of focus on a lot of other populations, like patients who are pregnant, older adults even, of course, type 2 diabetes as well. So why automated insulin delivery system is beneficial is the data shows kind of across all the different systems that there's increased time in range, especially overnight, decreased hypoglycemia and decreased glycemic variability, reduction in A1C, and one of the biggest things is that reduction in that burden. And then the patients that show the biggest benefit is actually the patients with the highest A1C. You can see the biggest reduction. So it's pretty fascinating that in a less than 10-year time span, kind of what's all come to the market. So Medtronic 670 was first brought to the market in 2016, so that's not even 10 years ago. And you can see the approval, the CAM diabetes one is approved in Europe. That's sitting at the FDA as well. So, but it's pretty impressive. So we're going to go through all the different systems and kind of highlight some things. I found this data just kind of interesting in terms of what patients worldwide are choosing. And so worldwide, Medtronic is the number one, then followed by Tandem, Omnipod. The MyLife Loop is that CAM APS. And then there's the iLet is only available in the US, and then there's slivers of patients on the looping. So I just found this interesting. So in terms of our systems that we have available, we are going to go through all of these in the next few slides. Thinking about who's a candidate, I think this has definitely changed over time, because historically we'd want to really have them kind of make sure that they were checking their glucose multiple times a day, you know, had their diabetes for a certain timeline, maybe showed better control. And now I think the thought process is that most patients should be candidates for automated insulin delivery as long as they can wear a continuous glucose monitor, follow the training that's needed and the regular follow-up. Obviously, cost comes into this. Being able to follow the hyperglycemia treatment recommendations and have some problem-solving skills. But really, candidacy should not depend on age, race, ethnicity, social economic status, duration of diabetes, where their current glucose control is, or how often they're checking. And so some general kind of tips for the system to work the best is, unfortunately, those patients that end up struggling the most as they convert to automated insulin delivery are those people that have great control and really spend a lot of their day focusing on their diabetes. The benefit that those patients can get is decreased burden, but sometimes they have a hard time giving up that control. So if their glucose goes high, the systems don't, we really need faster acting insulin is what the answer is, but it takes a while to bring that high back down. And so they end up entering fake carbs or phantom carbs. Maybe if the pump allows them, do a bunch of manual corrections, and then they get hypoglycemia and into that roller coaster. So, you know, making sure they have that expectation and know how the system works can be helpful. Of course, bolusing 15 minutes before is important. And if they're late bolusing, maybe not getting as much insulin. The hypoglycemia management, patients require less grams of carbs because the pump in advance is either suspending or backing off on that basal insulin. So it's kind of a double whammy if they treat with the typical 15 grams, as they end up getting a rebound high. And then with planned activity, it's really important for all these systems to try to use that exercise activity feature 1 to 2 hours ahead, especially if that they're doing aerobic activity that's known to cause hypoglycemia. So some other bolus tips. So we talked about pre-meal bolusing. Missed boluses, most of the systems really recommend that if someone doesn't pre-bolus but remembers within 15 minutes of eating, they should maybe only give 50% of what they're getting. So it may be either adjusting the carb amount, or they can override and adjust the insulin amount into the pump depending upon which system it is. So for example, if they're eating 40 grams of carbs, but you know, they ate and they realize that 20 minutes later they never entered it in, maybe they just enter 20 grams. So, and then if it's 30 minutes or more from the start of the meal, they may just want to acknowledge the glucose to get a correction and just forget about the carb entry at that point to just try to prevent that low. And if they're not sure what they are eating, you know, some strategies is to bolus for the minimal amount of carbs and then do an additional bolus. There's actually some features on the new twist algorithm that can be helpful in this scenario we'll talk about in a few slides. So exercise is kind of busy, but just to point out that As I mentioned earlier, turning the exercise feature on 1 to 2 hours prior to the activity if possible. And most of the algorithms are really kind of targeting that level around 150 so that they don't go as low during exercise. The eyelet doesn't have that feature, so that's recommended to disconnect the pump. And then the twist has a wider range than some of the other pump targets or numbers. They can select anything from 87 to 250. So just to highlight kind of a few things with Tandem Control IQ, which can be used on their traditional pump or the Mobi. One of the benefits that people might really find to be helpful for their lifestyle is to be able to bolus from the mobile app. The other nice feature is that, and we'll go over a case later, is that patient profiles. I use this a lot when following patients who are pregnant. When we find out they're pregnant, I have them duplicate the profile right away, so then they have their pre-pregnancy settings and they can turn that back on after delivery. Similarly, if someone does prolonged activity, maybe an exercise or active setting, different scenarios, steroid bursts as well. The nice thing about this pump, some of the pump systems patients get out of auto mode. This pump doesn't really do that as long as their CGM is working. And then this is the only system that has the extended bolus feature, which some people have really missed as they've moved to automated insulin delivery. So those pizza and high-fat meals that they find initially their glucose could drop or doesn't impact, and then they get this delayed high. This pump does allow patients to give a manual bolus or override in auto mode. That's something I think the educators don't really teach on a regular basis, but just because that can get patients into that roller coaster glucose control. And then in terms of what settings can be changed by the clinician and what is essentially taken care of by the algorithm. So with Tandem, this is one of the systems that essentially the basal manual settings is the foundation for the pump, and it adjusts up and down. So you can change the basal settings, and that does have an impact on automation. Similarly, the insulin sensitivity factor can be changed in the carb ratio. The algorithm has the correction target down to 110 that can't be changed. And the targets essentially is between 112.5 and 160. You technically can put sleep activity on or exercise activity on to get some different targets, but there's not multiple different options. And this is a system that has a range versus one set number. And then the active insulin time is locked in at 5 hours. So if everyone has the T-Slim simulator app or wants to play along, I was gonna just go through a little button pushing with using that app. So I kind of already even mentioned the example of pizza. So that's one of those meals that a lot of patients like to use an extended bolus feature. So what you do is every time to get into the pump, patients have to do that 1, 2, 3 to get in. And then you're going to go to bolus, and then you're going to hit the blue check. And then there's a spot where you can hit the grams. And let's just say the amount of pizza you're planning to eat is 90 grams of carbs. And then you would do the blue check in the upper right corner. Am I going too fast? Let me know. Are people still even getting the app? Whoever wants to. So you do a blue check and another blue check, and then there's a toggle, because a lot of people don't even realize that they have that feature on there. And so as you describe it to them, they're like, well, I never have that, because they're used to a blue check on the screen. And so they have to toggle on the extended bolus feature. So it's like toggling this on before they do one of the blue checks. And if they do that, there's an option to have them select a % now and a % later over up to 2 hours. So does anyone have any experience of what they recommend for what to do, maybe to start with for pizza? Or what would you tell your patient?
I think some of them already have a pretty good idea that have been doing some of that or had it from other systems, but some of it depends on what exactly it is they're eating.
Thin crust versus deep dish and some of that too.
It's the Chinese food, that's,
So
hot.
how is if it's 90 grams of carbs with pizza?
I mean, I usually start 2/3, 1/3, depending, but.
And do you do an hour or 2 hours or?
Depends on the moon phase.
Yeah. I mean, it's really a lot of it trial and error, right? Like, and maybe looking at it, like if I'm looking at it with someone and they're like, I just had pizza 2 nights ago, and we can kind of see how their glucose reacted to that. It'll help key in. But I mean, even starting with a 50-50 for 2 hours and then move that, maybe it needs to be adjusted. But so then they would go ahead and do the blue checks to get through, and then the bolus would be initiated. So we're going to move on to the next one. So that bolus, if whoever did participate in this, the bolus is running. So you need to push the red, the white X with the red in the background to stop the bolus so that we can do the next little mini case. But that just shows that patients can stop a bolus if they need to. So let's say you're seeing the patient and you want to change the breakfast insulin to carb ratio to 10. So to get through to that, so that 1, 2, 3 to get into the pump, you're going to go to options, and then my pump, the top one, personal profiles, and then whatever is on. So sometimes people have multiple profiles set, so go to the one that's on, and then you go to edit, and then you just have to click on that top bar of time settings to open up all the different times. And so let's say the patient typically eats breakfast at 6 o'clock. So what does your default have for what time you would switch the carb ratio to 10? I don't know if it defaults to the same for everyone. Mine is 4 a.m., so I would change my 4 a.m. setting and then go into the carb ratio and then select 10 and then the blue check, green check, blue check, and that's how that would be adjusted. So it can be helpful, especially if you're on call, to like know how to navigate that with patients. So I think, I'm sure the fellows, I don't know, do you all already have them? Okay. Okay, great. So, all right, moving on to Omnipod. So Omnipod is one of our automated insulin systems that essentially the algorithm learns the patient to adjust the basal. And so that's really important and we'll go over this in a few slides, but as patients change devices, like the newest iPhone approval, essentially they're kind of like starting over if they move from the controller to the iPhone because it has to learn them over again. It does have an option to manual bolus or override. Once again, just like Tandem, we want to limit that function. Patients really need to make sure they use this use sensor button here so that the glucose value drops in, but that also makes the algorithm use what the value is, where they're trending, and takes into account the insulin on board. So that's really important. How often do you find that patients come in and you're looking at the report and then you notice they've been in manual mode for like 3 days in the middle of the 14-day report? I find that happens, like they don't even realize it because this system actually can kick them out of auto mode. It's not really always known when and why because they didn't give us as much information about this algorithm, but essentially if their glucose is high and that max basal is running for a particular amount of time, it'll kick them out of auto mode. And what they have to do is they really need to acknowledge and figure out, is there something wrong with the sensor? So it'd be good to check with a blood glucose. And if everything's working okay, then they need to wait 5 minutes and switch back into auto mode. So what I find, and you can visually see here, that they use the colors blue and purple, which to me are not that different because I feel like, and so patients don't even realize on the screen that when they're in manual mode, this is the view they get, and then when they're in auto mode, this is the view they get. So the big difference is the box around the number is, in purple and kind of versus this one isn't, but I find that patients don't realize they're in manual mode. The one thing is that they change their pad every 72 hours, and then that reactivates auto mode. So it's not like some of these systems where they could be in manual mode for weeks or months and not even realize it. At least hopefully it's just a short time period, but that can be frustrating. All right, one of the recent updates with all the systems, I don't know if you had any patients that used the Eros pump in the past that really liked the custom food feature. That's kind of essentially back. So patients would go on to their menu here, go to custom foods, and then they can add all the different foods that they eat on a regular basis. And then that's in their menu. And so when they're going to bolus, essentially they go to bolus, and then instead of putting the carbs here, they would go to custom foods, find their lists. So let's say they're having breakfast, an egg, sausage, and toast with raspberry. So they just click those and it totals the grams of carbs for them. They add to the calculator and then they confirm. So they don't have to do the math, and it's just kind of preset. And so I think as educator team too, we could help our patients kind of find out if some people do. I feel like commonly people often eat a lot of the same breakfast, maybe the same lunch, more of a variety of supper meals. But if we can customize 2 out of the 3 of their meals easily with that, that's kind of a nice feature. So, all right. So here's the iPhone compatibility. I kind of mentioned this already, that the system kind of has to start over learning them. A couple tricks with this. One, we need to make sure their manual settings are up to date. Also, you could have the patient change their pod at a 40-hour interval instead of waiting 72 hours, because that will help the system learn and start using the automation sooner. The one trick with all this, with all these approvals, it's awesome that our patients have more choices with CGM, but it's a little confusing to keep track of all this. So if someone essentially uses the iPhone current day, they can only use the Dexcom G6, so do not upgrade them to the G7. If they're still using the controller, that's where they can use the G7. And then the recent approval in the last few weeks is the Omnipod 5 with the Libre 2 Plus. So you can see in this upper right corner here that it has Dexcom G6 and Libre 2 listed on there. So patients can transition from the Dexcom G6 to Libre 2 if that's what they're 2 Plus, if that's what they're doing. But there is no smartphone compatibility for the Libre 2 Plus. So patients have to start, deactivate, and view the glucose with the controller. And so I think this allows some of our patient population that haven't been able to use this device in the past, because the only way in the past people could use Dexcom and Omnipod is you had to have a smartphone. This is a way that you don't have to have a smartphone and can use this system. It would be with the Libre. So, all right. So in terms of setting changes, this system, the algorithm essentially adjusts the basal, and it does that by kind of alerting the patient. There is no auto correction feature, so I would consider this algorithm probably the most conservative out of them all at this time. As a clinician, you can change the insulin sensitivity factor, the carb ratio, the auto basal targets. There you can pick 100, 110, 120, 130, 140, and 150, and then the active insulin time can be adjusted, which I feel like I have found lately shortening that active insulin time almost to 2.5 hours has made a big difference for the system. So moving on to the Omnipod Simulator app. So if you got that app, there's an option now to have this look like an iPhone, but if you can toggle on the bottom once you get to this screen, so that because some people might have Androids and some people might have iPhones, so we can make sure it all looks the same. We'll just look at the controller view. So if you get anyone that wants to follow along, go to the Omnipod 5 app, and then make sure that is toggled on. And then I feel like sometimes when I first go into the app, it asks for a pod change. Is that what people are seeing? Yeah, okay. So we'll walk through that. So let's say we need to change the pod. You can kind of see, I don't want to say how easy this is, but it is a system that isn't as complicated as some of the other ones. So you would go to pod info, kind of towards the upper right corner. You go to view pod details, change pod, and then a pop-up will come up, deactivate your pod, and you'd push yes. And then it's asking you to remove your pod, so you'd push continue. and then you're going to set up a new pod. So essentially you're going to fill the pod with insulin, and then you want to keep that pod in the tray next to whatever device they're using, and then push next. And then recommended to clean the site where the Omnipod is going to be placed. There's a feature on this where they could record where they're placing the Omnipod to help with rotation if someone wanted to use that. Otherwise, essentially, they're going to remove the pod needle. They'll push start and it'll say, is it securely attached to your body? Yes. And then it'll insert the cannula. And then it'll ask if the cannula is properly inserted, and it'll show a little pink on the top of the pod to confirm that it is placed properly. So then yes. And then this is that question where it says switch to auto mode. So that's where with every pod change, it will ask them. So any questions with that? Did I go too fast for anyone that is following along? Okay. All right. So another kind of scenario is just to kind of show how to bolus with this system. So you would go to the bottom here, select bolus, go ahead and enter the carbs. So let's just say they're eating 45 grams of carbs, and then go to use sensor to have that glucose be acknowledged, because that takes into account the trend and the insulin on board. And then in the bottom right corner, they'd push confirm and then go ahead and start. So that's what's involved with essentially starting a bolus. And let's say in this cold weather, you're going to bundle up and go for a walk in an hour after this Grand Rounds is done. So if you wanted to turn on the exercise activity, you're going to go to the upper left corner with the main menu, and then it'll say activity, and then you can set the duration. So if this was the case, it's happening in an hour and I'm walking for an hour, I would at least put 2 hours and confirm, and then it will start that exercise activity. Any questions with Omnipod? So we'll move on to Medtronic, the 780G. So with this system, their newest sensor that works with their pump is the Guardian 4, and we want all our patients to be on the Guardian 4 because this is the sensor that they don't have to calibrate, and that makes a big difference. This is another system like Omnipod that needs to adapt after setting changes are made, so it learns the patient and adjusts the basal accordingly. There is no option to give a manual bolus and override unless they get out of SmartGuard. They could do that, but if they're in SmartGuard or auto mode, it wouldn't allow them to. This, I would think, is one of the most aggressive algorithms. So if you have someone that wants very tight control, there's auto corrections that are every 5 minutes. And so this algorithm can get their time and range, I've seen, in the 90% with not a lot of extra burden. The sensor needs to catch up, but the algorithm is pretty impressive. In terms of auto mode exits, they can still occur, and so they would have to turn them back into auto mode, and that's why it's really important to make sure the manual mode basal rates are up to date. The pump with all those auto corrections can do that every 5 minutes, and so one thing on the report that can kind of help guide if you need to make changes is if they're not meeting their glucose targets that you have set for the patient, and that auto correction is greater than 30%, then you may want to kind of dig further. If all their numbers are at goal and it's 40%, that's okay. It's helping them a lot, right? But if their goals aren't being met, you want to kind of think, do they need help with carb counting, or are they missing boluses? Does the carb ratio need to be changed? And then the CareLink Connect app is, people can view the data, but they can't bolus from. So in terms of which settings can be changed by the clinician, that's the carb ratio, the auto basal targets. This system allows for 100, 110, and 120. And then the active insulin time can be changed. And they have a lot of real world data that shows that patients do the best with getting those high time and range if you set the target at 100 and you set the active insulin time at 2 hours. And I feel like sometimes as we're transitioning patients, we're like kind of doing that like slowly. You could probably just honestly go for it. It's I think the target, that's one thing, but the active insulin time is kind of that level for how aggressive that correction is going to be. So especially if you have a patient that wants tighter control, I would just go for that right at the beginning. And unfortunately, I don't have an example case with the simulator for Medtronic because it has you select English and set the date and the time and all the settings. And so I didn't want to take the time to do that. So there is a simulator app, so please feel free to add that to your phones and play with that on your own time. Moving on to the islet bionic pancreas. So just to remind people, because we don't have a lot of patients on this system, and it's kind of definitely different than our other automated delivery systems, is this is essentially fully automated in that the patient really just only announces their meals. So there's no programmed basal rates, there's no programmed correction factors, there's no carb ratios. If someone's glucose goes high, they can't give a correction. They can't push a button to get more insulin. It's just really giving a lot of control to the pump. And so it's just expected that these patients should be carb aware. And we'll go over that in a couple examples. The biggest thing as this system essentially learns them is that they need to kind of be entering in their usual for me meals for at least 3, maybe up to 7 days. So the system properly learns them, because if they're having a high carb meal, low carb meal usual at a certain time, the system's going to have a harder time adjusting what those insulin needs are. If this, I think a lot of our patients have a lot of beeping going on all the time. The islet, if the islet has an alarm going on, most of the time you have to act on whatever the system is telling the patient. And then we really need to make sure that all our patients have ketone strips and an action plan with this, as well as they need to understand that they need to carry their blood glucose meter if they would have a sensor failure or run out of it. So unfortunately, this system, if they don't have a CGM working, the pump stops delivering insulin after either 48 or 72 hours. And so they could enter BGs for up to 72 hours after their sensor failed. But if they have a distributor issue where they're not going to get it for a week, they may have to go and go back to injections. So it's really important for our patients to understand this. And then they should always treat if they're getting a hypoglycemia alarm. And New is an islet follow app, so other family members or caregivers can follow along with this. In terms of setting changes, well, there's not a lot of settings. So the only thing you can change is the basal targets. There's an option for 100, 110, 120, and 130. And it's called usual, high, lower, I think is the terms, but that's essentially what it's targeting. So they don't have a technical app, but that you can go to the website, and I've created that just to add it as an app on my phone. So if anyone else has done that or wants to go to the website and follow along, I have a couple scenarios for the islet to share. Okay, so you go to the simulator app here, and then it should be this screen. So essentially, let's pretend your usual lunch is ham and cheese sandwich with apples and carrots, but you decide you're going out for noodles and you're having mac and cheese with grilled chicken and a cookie. So you would go to your unlock screen, to your fork and knife, and then you'd bring the drop-down menu for the meal type, and you're selecting lunch. And then at that point, the patient can select either usual for me, more than usual, or less than usual. So what would you suggest this patient pick? More, yeah. So, and then they would go and just deliver the insulin essentially, and that's what's involved with that bolus. And then this is that scenario. Let's say the Dexcom DME order is late and they're out. I just wanted to show where patients, especially if this is an on-call question that would ever come up, you can go to the main menu in the upper left corner and then go to this essentially kind of history button, which is this arrow circled backwards, and open that up. And then there is an insulin history button, and it keeps track of what essentially the basal requirements that the patient is needed with the algorithm, and then what their usual for me breakfast, lunch, and dinner are. So that would be a good guide for them to know what to do as a backup plan. All right, moving on to twist. So, and I have some demos that I can pass around, and then we have some representative from Sequel MedTech here where afterwards, if anyone wants to actually play with the looping app and the actual, these are just the demo ones, but if they want to play with the other ones, you can. But essentially, this is the pump, and then this portion is replaced. So it's kind of like, obviously, the name twist. You need to line up there's a line kind of here that you have to line up these two lines here to get it to open. But I will pass these around for the people that are here, and you can play with them. So essentially, the algorithm on this pump is essentially, it's called the tide pool loop algorithm. So there was a do-it-yourself community that had people with diabetes or family members with diabetes that created their own community and created essentially an algorithm. And so a lot of people that loop, the app is actually lives on the smartphone. And so they always have to have their smartphone with them to have the loop work. This system, the algorithm actually lives on the twist pump. So essentially someone could go out for a run or do anything without their smartphone, and the pump still functions. Obviously, if they are wanting to bolus or anything like that, they would have to have their phone or their watch to do that. So this talks to an unknown continuous glucose monitor to be determined, and is only available using the iPhone or the Apple Watch at this time. So let me see. All right, so as I said, iPhone only. We don't know which CGM is going to be hooked up with this pump at this time, but the options, patients can either wear this as an on-body patch, or they can wear this with a clip. And so the only infusion set option initially is going to be the Clio 90. There is an option for patients to bolus off the pump, kind of like the Mobi people can do that, just for like a quick bolus. The Apple Watch can allow for bolusing. The data is going to be shown on Tide Pool. There's going to be a share app, and then there needs to be a battery change with each pump change, essentially. So this is approved for 6 years and older. The one kind of difference, as it's more a little option, is more of like a patch pump, is that it holds more insulin than our other options. So Omnipod just holds 200 units. The T-Mobi also holds 200. The Twist holds 300. Planning to run it through the pharmacy benefit, which I'm, as a pharmacist, of course, I'm excited about that. But I just think the process for patients and as clinicians ordering is so much smoother. So that is huge. As I mentioned earlier, it uses the Tide Pool Loop algorithm that we'll talk about. One feature that's really a benefit for patients is that they are able to select a food type for the bolus speed. So essentially, they're selecting the absorption time based on the meal. The default is the lollipop, which you can see here is a default absorption time of 30 minutes, a taco, which is 3 hours, and pizza, which is 5 hours. So it's kind of like a little bit like the extended option, or even a shorter, I guess, absorption time. So that's a feature, and there'll be other emojis that patients can select and kind of learn what they need for different absorption times. The other thing is that this algorithm is almost just as much an insulin algorithm as it is a carbohydrate algorithm, as the model has impacts the number of carbs entered and keeps that into account in terms of looking at that 6-hour forecast we'll show in a couple of slides. So I think that the other awesome feature is the scenario where people don't know if they're going to eat all of what they are planning to eat. And so patients can actually go back and adjust and tell the pump what they did eat. So if they were planning to eat 60 carbs, they enter 60 carbs, they're done eating, and they realize they only ate 40. They can tell the algorithm that. And yes, we can't take insulin away, but it can help moving forward adjust insulin based on those adjustments. And I believe they can go back up to 12 hours, is it?
Which I can change it up to 12 hours.
Yeah.
It's not going to impact insulin.
Yeah. Which I feel like it's crazy to be that far back, but I think they're going to have the most impact the closer the time to eating. But I think that is a great feature. Some other things when setting up this system is that patients are going to have to set a bunch of different target range options. So they will go ahead and select a glucose safety limit. So essentially this is set anywhere between 67 and 110. And if the glucose is ever predicted to go below that safety limit in the next 3 hours, the pump will actually shut off insulin delivery. And that can adjust and update every 5 minutes. And then the correction range is really essentially the target range is what we typically call it. And that algorithm is actually, if it's determined that more insulin is needed, it will actually identify what that amount is and give it as a temporary basal over the next 30 minutes. And it looks at kind of what's predicted to happen. We'll show on a couple slides of a 6-hour forecast of what's happening. And it can keep updating every 5 minutes. So let's see. In terms of the pre-meal range, this is another kind of nice feature from the standpoint, you could maybe think of this as a little bit of a helpful tip in terms of the pre-bolus timing. I don't think you have to kind of, if those patients don't pre-bolus 15 minutes before, I don't think they're going to have the same impact on this system as other systems. And why that, as long as they have this set kind of low enough. And so patients can select anywhere between 67 and 130. And essentially what it does is really helps prevent, because a lot of our systems going into the meal, the insulin, the basal suspended. And so sometimes that could be suspended for an hour or 2 hours where they don't have any insulin on board. And then they go ahead and eat, especially if they eat something that's high carbs, they just go way up. And so this kind of allows for a lower target. So what a patient does is actually, if they know they're planning to eat or they think they're planning to eat in the next hour, they can turn this on. If they enter carbs, it turns off. If they decide, oh, I'm not going to eat for a couple hours, they can manually turn it off, or it just goes off after an hour if they don't eat. So it's kind of a nice feature to help prevent those post-meal spikes. And then, as I mentioned earlier, they do have the workout range. So here's kind of the algorithm, which is the predicted glucose minus the target glucose divided by the insulin sensitivity factor. And it looks at a 6-hour forecast taking into account the therapy settings, the insulin on board, their carbohydrate history is important too, as well as the past 30-minute CGM trend, as well as the future. And so the next few slides are a couple of visuals. So this is a patient that has a current glucose of 117, and they have a range selected of 90 to 120. So the middle of that range is 105. And so they want to get to that, but the 6-hour forecast based on all these other factors is predicting that the glucose is going to end up in 6 hours to be 85. So that's below that forecast by 20 points. And so then it will back off essentially on the amount of basal that's given temporarily. And that can just be even adjusted every 5 minutes. They'll keep it, the system keeps calculating that. And then on the opposite end, if the patient will require an increase in their basal, so here the glucose is elevated at 188, and the predicted 6-hour forecast is that it'll get down to 160, so it'll go down, but it's not going to get to that target of 110. So the glucose needs to drop by 55 points. So essentially the algorithm is using this math, essentially, that I went over before, as well as all these other kind of parameters to help come up with the amount of increased basal, temporary basal that's needed and dispersed over the next 30 minutes. And then if the patient initiates a correction bolus, it does the same math calculation, but actually gives it as a bolus versus spreading it out over 30 minutes. And then that carb entry, it does a bunch of different predictions as well. Like the black line is assuming that they didn't get any insulin and what their glucose would end up being. And it forecasts trying to get them to their target, essentially. The big thing with this is that, well, I think I'll go over that in a couple slides. So a couple of things that are different. I highlighted probably a few things already that's different compared to some of our other systems that are currently on the market. One thing I didn't mention yet is the way that insulin is delivered. They have, it's called iSure technology, but essentially it uses sound waves to directly measure the volume of insulin that's delivered with every microdose. So it uses 4 points of accuracy checks to make sure that it's done appropriately. And the big thing why this can make a big difference is there's a lot of patients that you don't know if you have an infusion set issue or what the problem is for why they're having a high. And so this detects an occlusion within 19 minutes, which they have some data that shows that it's like essentially 9 times faster than all these other systems. And so that can make a big difference for people kind of wondering, do I change up my set? Which we definitely want to teach patients, when in doubt, change it out. But obviously that can be a hassle. And so if there's something that kind of tells them that there's an issue, that's important. We talked about the retroactive meal adjustments already, so they can, if they ate less than they planned, they can adjust that. And then we already talked about the pre-meal preset, where they can lower that target when they turn that hour. They're going to plan to eat an hour, and that can help prevent that post-meal spike. So in terms of the settings that can be changed, essentially the only one that can't be changed is the active insulin time, and that's that 6-hour kind of forecast. The other thing to make note, some of our other systems on the settings, you can set a max basal rate, but it really doesn't impact the algorithm. This does. So it will not allow the basal to go above whatever that max basal rate is. So it is recommended to kind of look at where their settings are and set that 2 to 4 times higher than one of their scheduled basal rates. And here's the tide pool loop report, which we don't have a lot of experience using tide pool yet at this point, but kind of has all the information that we're kind of used to from some of our other systems. Moving on to automated insulin delivery in type 2 diabetes, I think this is the direction that that things are moving. We did get the approval of the Omnipod 5 with the secure pivotal trial, and I'll talk about that results on the next slide. But Medtronic and Tandem currently have either completed or ongoing trials as well in type 2 diabetes. So the secure trial was with using Omnipod 5. It was ran over 13 weeks and had 305 patients with type 2 diabetes. It had a good selection of more diverse patients with 46% Black or Hispanic. 73% of them came from multiple daily injections, and there was a good chunk of patients that were on a GLP-1, which I found to be interesting. So in terms of the mean change over that 13 weeks, 0.8%. And with all of our other systems, the people with the higher A1Cs, so greater than 9%, saw a reduction of 2.1% compared to baseline. And so I think that the data shows there was no increased hypoglycemia. There was an average reduction of total insulin by like 23 units a day, and decreased diabetes distress was reported as well. So I think this is really exciting data, and I think we need to be thinking about our patients that are on basal bolus and be considering Omnipod 5. They actually even had some in this study, an arm with basal only patients too. So I think hopefully those were some helpful updates with automated insulin delivery. And I think, as I just kind of pointed out, with type 2 diabetes kind of being a new population, we don't have, at least the people that I don't see, there's not that many type 2 patients on automated insulin delivery, but I think there are those patients out there that would benefit. And so I think really considering it an option for anyone and really not acting as a gatekeeper is really important. So using our diabetes educators to really help kind of see if the patient is a candidate or not. and see what option would be best for them. I think it's really important to set the expectations of what the systems can do. And I find this is the biggest deal for those patients that have that tight control, that are micromanaging all the time. And then ability to carb count is the best scenario, but it shouldn't be a requirement. And then I think it's really important to use our educators to help them determine what is the best fit for patients. Someone that wants aggressive control, maybe the Medtronic is a better fit for them. Someone that doesn't want tubing, maybe the Omnipod 5 is the best for them. You know, someone that is constantly on and off steroids, maybe the Tandem, because then they can set a different profile. Someone that doesn't want much control at all, maybe the iLet is the best. So lots of different options that we have, and so we really need to help patients figure out what the best option is for them. And so the next few slides are automated insulin delivery comparison. If any of you want the slides, Angela can send them to you. I'm not going to read this, but this is just kind of a nice comparison to show the differences between all the different systems. So there's this slide, and then this next one just kind of focuses a little bit more on the algorithm and targets and what the pump can do. And just to kind of summarize some of these main concepts with these systems is there's options for treat to target or treat to target range. So Tandem is a treat to target range. Twist has the option to do either. Medtronic, Omnipod, and iLet is a treat to a target number. And then the level of basal automation is different between systems. So Tandem and Twist are kind of what we consider semi-automated. So it uses the basal rates that are set manually as the foundation to adjust up and down, versus all the other systems are learning the requirements that the patient needs. Automatic correction bolus, Omnipod and Twist don't have this feature. Tandem can do this up to once every hour at a 60% correction, and Medtronic and iLet can autocorrect up to every 5 minutes. So just kind of some tips for success. I think getting those basal settings, even with automation, and the backup settings is important. Getting those bolus calculation settings right. A lot of our systems, we need to be more aggressive with the insulin to carb ratios. Acknowledging some carbs or acknowledging eating is important, and timing those boluses properly, as well as managing the pump, CGM, and infusion sites if there's any issues, and then adjusting based on lifestyle factors that are playing into, like exercise, stress, hormones, fluctuations, those types of things. So the second half of the presentation, we're going to go over some cases. So the virtual group is going to work with Allison, and then the rest of us will stay in. If anyone wants to stand up and stretch, we can take a minute, or if anyone has any questions before we get started on that portion, feel free. Yeah.
The Libre 2 Plus of Flash CGM?
No.
No.
Real time. Yeah. So the only time they have to scan is to start the sensor, and that's with the Libre 3 Plus.
So what's the difference between 2 Plus and 3 Plus?
Really not much besides which automated insulin delivery it works with for the most part.
So I think Mickey told me if you're not using 2 Plus with the pump, it actually is a flash system.
If you're not,
That's what Lisa told me last week, and I had been looking, so I'm still not sure. It's possible, but I'm not 100% sure. I never used the Libre 2 Plus, to be completely honest with you.
I was going to say, I don't think I've ever ordered it unless someone was using it with a pump.
So I think only the 2 Plus is only compatible with a pump, and the 2 is what you would use if you weren't using a pump, and that's why the 2 remains flash, with the 2 Plus being streaming.
Okay, because you can order the 3 Plus as a standalone.
They can
So-
use the 2 Plus as a standalone. Oh, they can?
Yeah.
Yeah, you
So-
can, and I just double checked so I think it is a flash, but not when used with a pump, obviously. So if you're using it with the pump, it does function as a standard
I swear we
continuous
we
glucose
ordered-
monitor.
I guess we'd have to clarify that.
There's really no reason to order a
But-
2 or 3.
Yeah, don't order it. Order a 3. That's,
Yeah, I
that's
mean,
the
most
answer.
of us are all
I don't
using
understand
the
order
3,
plus
so it doesn't
forever.
matter.
Exactly. Yeah, and 3 Plus at this point. I mean, it's smaller. I don't know. All right, any other questions?
Means for type 2 diabetic, their insulin requirements are usually higher.
Mhm.
So, with the approval of AIDs in type 2, so they would have to change pump like almost on a daily basis.
So it depends on their insulin requirements, but yeah, if someone requires high amounts of insulin because the Omnipod only holds 200 units, they could get, most of the time I would think most of our patients could get to 48 hours. But off label, that's where I personally would use a concentrated insulin, and I would only use U200. I would never use U500, but that allows for them to get on a cycle of every 72 hours for most patients.
And in your experience, the coverage is okay for type 2 and then Omnipod?
So I don't have a lot of experience yet, but I've heard that the coverage is good. Yeah, I think when you have the secure trial, hopefully one of my upcoming residents will present that trial once it gets published. They keep saying it's going to be published soon, and it hasn't been yet. So we'll definitely want to review that. But yeah, so any other questions?
And someone communicated with radiology about 2+ and 3+ that don't need to get removed, right?
They don't need to.
Right, but
Yeah.
do the radiology know about it?
Oh, that's a good
Because
thought.
the radiology make patients remove all the pumps, no matter what.
Yes.
It's on
So-
my to-do list. The problem is we have bigger issues with pumps being removed. But yes, it's on my to-do list.
Yeah, I know I went to them back in the day when we had to make sure they weren't like essentially wasting people's sensor, because we added that to a screening question when they get called and they schedule, they ask that. But now it's going to be a little more confusing from that perspective, because some of the systems they do need to take off, and some they don't. Hopefully with time.
Need is a relative term.
True, that is true. I think the big thing is just verifying accuracy, right? But they'll tell them that though, and that's what patients know. So I feel like even the patients that I've talked to already about wearing it with a Libre, they feel a little uneasy because they're like, well, I always had to take this off. So
Libre doesn't have like a little wallet card for patients, huh?
yeah,
Really?
Like pacemaker?
Right. Yeah. You just hand it to the radiologist and say, trust me, here.
yeah, that's a thought. Did you have another?
I was just, it's not a question for you, it's for the audience. I was wondering if what people's experiences with the iLet have been, because mine, Erin and I have had only bad experience. But
Mine's limited. I have the whole idea. Yeah. I think I still have somebody that's on one, but.
Yeah, I have an N of 1. It's actually going pretty well, admittedly. It has sort of taken some of the control and fidgeting and playing with some of the settings away from them. So it allows them to focus more on just entering insulin when they're eating. And it actually has gone pretty well. But I know we've all talked that we've had a couple where they went into DKA or it did not go well. And so I think as long as we have that action plan and the educators are now, I think, a little bit more well-versed in this, it's going better. So I'm not shying away from it, but it's a limited.
And that's where I found it interesting. I showed that slide that in the US we have 10,000 users. So I feel like, we don't have a great representation of the use of the iLet, but it is being used. And on the ADCDS group that I'm on, the listserv, some clinics have hundreds and hundreds of patients that they follow and do well. And so, I don't know. I feel like it should still be an option for some, but I feel like the education piece is very important. So, because I feel like the patient population that we tend to go towards using it is the hands-off patients. And we need them to be hands-on if their CGM stops working or their glucose is high and they need to follow that ketone action plan. So that's where I don't know if we change the process leading up to the iLet to have more than one visit prior to, depending upon the patient. So any other questions?
I'm just going to change out so that way the virtual group is virtual.
Oh, okay, great.
Hey everyone, thank you so much for staying on for the case presentation. I will be sharing my slides here briefly. All right, there we go. And we'll talk through a couple different cases. So the cases, this grand rounds will be focusing on each of the pump systems and different unique scenarios with each of them. So we'll just jump right in. Hope for this to be interactive. So please jump in, pipe in with any thoughts throughout the cases. All right, so case number one is going to be one of the Medtronic 780G, and talking about a person who was transitioning from previous non-automated insulin delivery pump systems and is now a new first-time user, automated insulin delivery user. So case number one, MT. So MT is a 73-year-old female with type 1 diabetes diagnosed at age 19 years old. She has been on an insulin pump since 1996. She's currently using the Medtronic 770G system, but she is using it with the Dexcom G6. So even though it is technically an automated insulin delivery pump and has that capability, because she's not using it with a Medtronic sensor, she's unable to use the AID functionality. The 770G is out of warranty, and she has received supplies to upgrade to the 780G. She has never been on an AID system before. On the right, you'll see her insulin settings here, her pump settings here. All right. So this is February 2024, before or in current day, but when she is still on the 770G plus the Dexcom. Looking at this, does anything stand out to you at all about her pump report? All right, so just some things to kind of note is that her time in range is at 65%. So it's relatively good, but definitely could be improved. She's having about 2% of lows. You'll see she's entering about 3.3 carbs per day. And her basal bolus split is nearing 50 to 50. So 53% bolus, 47% basal. All right, and then looking at this pump report, does anything stand out here in terms of how she's utilizing her pump?
I mean, she's just microbolusing throughout the day.
Yep, exactly. That's what we noticed as well. So yeah, she is just doing a ton of corrections. So going back to that summary page, she was entering about 3.3 meals a day, but then now finding herself correcting a lot throughout. So now it brings us to July 2024. She started the insulin or the 780G pump back in April of 2024, but she's really having a hard time adjusting to this new system. She feels that it can take as long as 12 hours to get her glucose to come down when it's high. Again, her settings here are on the right for reference. Of note, they are unchanged from her settings with the 770G. All right, what's Ann thought about her pump report now that she's on the 780G system? I'll give it a few more seconds here and then can kind of kick off some ideas. So some things that stood out to me was that you can see that the auto mode is disabled twice by the user. So if the 780G system auto mode gets disabled much less frequently than the 770G, but it looks like she has manually disabled this twice. The auto correction is greater than 30%. So if you recall from the earlier portion of the material presented, if it is above 30%, it's a good idea to kind of examine why it is that she's getting such frequent auto corrections. Her active insulin time is at 2 hours and 30 minutes. And then her carb entry has greatly increased. So she's now getting 6.7 carbs, or entering, at least she's entering 6.7 carb entries per day. Additionally, we are kind of noticing this rise in glucose while she's sleeping. There's her daily report, and I think a lot of the things that we talked about on the last slide are seen here. So as Dr. Ross had called out earlier, with the frequent autocorrect or the frequent corrections that she was giving when on the 770G system, she's sort of stuck with that same thing. However, now it's turned into more of a fake carb entry to try to get her glucose to come down. Then looking at this compared to the days where she really is entering those 3 carb meals a day, what do you notice? I guess between the 2 days, which day would you say has better control? So the days where she's entering true carb, she does tend to be on less of a roller coaster, much more stable, and her time in range is greater. This can be something good to demonstrate to patients, to show them the 2 days, the days where she's doing the fake carbs versus the days where she's just entering carbs as she's truly eating, and how there's much less variability on those days. Additionally, as we were kind of talking about her manually suspending the pump, I have a box here of what happened when she manually suspended on July 2nd, that was. What do you all think might have happened here? So it's possible, this is more of a speculation, but it's possible that on July 1st, she may or may not have had a pump site issue. I think she had done a set change, you can see right around midnight, that, it's possible that there might have been some sort of occlusion or kink that caused her glucose to go up really high. But then in talking with her, then what we learned was on the 2nd, where she went up to like that 400 with the blood glucose meter and drastically fell down to the 59. She actually manually suspended the pump as shown there, and gave herself an injection of insulin outside of the pump, then restarted her pump and drastically dropped. So to avoid doing this in the future, what different recommendations could be made for her?
I mean, she could change it sooner when she notices that, number one.
Mm-hmm.
Yeah, I'm
definitely.
interested to get your thoughts in terms of the pose. I mean, she could say that she bolused and give like a point, a mini bolus. So the pump thinks that she bolused, and it won't be maybe as aggressive with auto corrections when she's kind of coming down and crashing.
Oh yeah, that's a really good thought. Yeah, something that
Um,
Erin and I were kind of talking about too is another idea would be either at that point just manually suspending the pump for a longer period of time before restarting it if she knows that she had just given a bolus outside of the pump, and ideally trying to avoid doing boluses outside of the pump if they can't be avoided.
The other thing you could do is I suppose you could just turn off the auto corrections and make it function like a 770G pump.
Oh yeah.
So when there's I forget what the terminology is in the actual pump, but basically if you turn off, I guess auto corrections, or I forget what the term, but you're basically causing the 780G pump to function like the 670, 770, where it's not giving those every 5-minute corrections. So you could, in theory, do that and then turn it back on later, to maybe minimize some of that additional correction insulin.
Yeah, that's a really good thought. I hadn't thought of that either. So yeah, to avoid getting so much insulin. So thank you. That's a great thought. Any other thoughts on this daily report? And then the very last thing I guess that we'll call out here is that, as we're seeing that she's manually, or that she's disabling the smart guard a couple times, there was just kind of, I think, a miscommunication or gap in understanding. She was thinking that every time that she did a set change that she needed to disable the smart guard and go into like her manual basal settings. So there's just a little bit of fluctuation there. So a point for re-education. All right. Then something else to think through with this is with the 780G system and with most insulin pump systems, we do want to make sure that even though the basal rate that we're setting is not impacting her basal settings when she's in like the SmartGuard technology, in the situations where she does revert back to her manual mode, we want to make sure that her basal settings are up to date. So here's kind of just a comparison of what her manual settings are versus what she's getting. So if we, I guess, what do you think of these? Are these similar enough? Could they be improved?
It looks like she's needing more basal if she goes into manual mode.
Yeah, exactly. So her manual mode settings are probably underestimating what she needs now, which could be, you know, a result now that she's switching from her non-automatic or from her non-AID system to the new one. So how would you go about calculating out what she needs or how to update her settings, I guess?
I guess I would just take the auto basal, the 20 divided by 24 hours and just do a simpler basal rate.
Yeah, exactly. So that's essentially what we kind of have on the slide. So total daily dose divided by 2, and then dividing that further out by 24 hours at her basal settings. So then we get to the 20. It does happen to be matching what she is getting right now in basal because she is kind of at that 50-50 split for basal bolus. A lot of times patients on automated insulin pumps may not actually have that 50-50 split. So just something to kind of be mindful of, and, you know, calculating out the total daily dose may be more of an accurate calculation if someone's really off on those ratios. And that gets us to about 0.83 units per hour. And so we could change just her 12 a.m. setting to 0.8 units per hour and could have that, you know, even simplify those basal settings to get rid of the multiple settings that she has per day, just running continuously at that. Okay, so just this is kind of a summary slide of case. So our plan, we want to always look at identifying and correcting reasons for hypoglycemia. So if injecting a correction dose by a syringe, we would recommend suspending the pump for an hour or so, or something that we didn't talk about, it would be also potentially setting a temp target to try to raise that glucose threshold. Then identifying reasons and correcting for hyperglycemia. So she could be missing boluses or bolusing late. So as a reminder, to pre-bolus 15 minutes prior to meals. Over treatment of hypoglycemia was something that she had reported when she was in clinic. When a person is switching from a non-AID system to an AID system, they really only require about half of what they used to for the treatment of hypoglycemia. Now that the basal gets suspended when it's predicting hypoglycemia is going to be occurring. We can optimize her active insulin time or insulin time by changing it from the 2.5 hours to the 2 hours to make those 5-minute corrections a little more aggressive. We could, just looking at her rate, besides some of those other things that were going on, we could strengthen her ICR post-breakfast and post-supper or bedtime to try to prevent such hyperglycemia. Also weakening her ICR post-lunch to help avoid basal suspension as she was having, or as glucose was going up later. And then reverting to manual mode, make sure that her basal settings are appropriate. And then education pieces for the patient. So avoid changing the infusion set before bedtime if possible to hopefully catch some of those set change errors. Avoid entering fake carbs, and we could provide examples to the patient of the impact of fake carbs, such as those 2 days where she had the drastic difference in control. Miss bolus and late bolus education. Information about hypoglycemia treatment and not overtrading. And then for this patient, with her giving those frequent fake carb entries, just reminding her that the pump works best when you're following the rules of the pump. So allow the pump to kind of do what it's going to do rather than entering in those fake carbs, and to, you know, give up some of the controls and reduce some of the burden of management. Ooh. All right, so that was all for case number 1. We'll move into case number 2. Which will focus on the islet pump and hypoglycemia occurrence. So IL is a 53-year-old female with type 1 diabetes diagnosed at age 14. She started the iLet pump back in April of 2024 and is a first-time pump user. She is not familiar with carb counting. Her meal schedule, she typically has coffee only for breakfast, lunch is between 11 a.m. to 1 p.m., dinner is 5 p.m., and then she'll have like a snack around 7 p.m. of cookies, cheese, or coffee and milk. So when she starts on the pump, shortly after, a couple weeks later, this is what her pump report looks like. What are initial thoughts on this, or does anything stand out? So overall, for starting the pump, it looks like she's actually doing pretty well with 76.5% in range. She's entering about 2.6 carb entries per day. And the 76.5% in range with an incidence of about 0.3% hypoglycemia. This is just kind of her daily profile for reference. As you can see, it looks like she may be late to some of her carb entries, as it looks like her glucose is sometimes rising before breakfast. And then lunch, she's usually pretty flat. She does have an active job where she's very active during the day and burns a lot of glucose. So 3 months later, she returns to clinic. She reports that she has a lot of concerns for hypoglycemia. She's 40-hour work week, which includes cleaning commercial buildings. All right, what do you notice in this pump report in comparison to the last one?
Not entering any meal announcements at lunch and supper.
Yep, basically not entering anything, 0.1 carbs entered per day.
I was trying to answer a question and it wouldn't let me. Sorry, my mute has been off, Allison. My apologies. It wouldn't let me talk to you. Now it does.
Thank you. Sorry, did you have it? Did anything stand out on this slide that you wanted to?
It was basically what Nicole is saying.
Yep, yeah. So no longer entering carbs. Her hypoglycemia though has increased, and she's now at about 2% of hypoglycemia, and that's something that she was reporting as a concern. This is what her daily report's looking like now. You can see that there's no carb entries other than Friday, July 26th. She, most likely entered that in because she was high and was trying to bring her blood sugar down. So she reported a breakfast at about 3 a.m. But other than that, hasn't been entering any carbohydrates at all, but you do see these big dips where she is having hypoglycemia. So I guess before we jump to kind of solutions, does anyone have any thoughts on this? What could we do to try to prevent the hypoglycemia in the iLet pump where we don't have a lot of ability to adjust settings and a patient's having hypoglycemia despite not entering carbs at all?
Can you adjust like target?
Yeah, absolutely. And how would you adjust that?
Oh gosh, where was she at to begin with?
Let me see. I think she was just kind of at the usual target. I don't think it says it on this slide. But I think she was at the usual target.
Okay. I'd have to go back to the slide that I screened. I'm guessing I'm not quite sure. I don't have a lot of familiarity with the iLet.
You can kind of tell though she's probably at 110 because that purple line is where it's set to. So it's probably 110. It's hard to tell, but that would be my guess.
Yeah, so that's a great thought. So so we're noticing that she's having these drops in glucose between 7 and 10 a.m. So she really has two options. So probably the most practical option would be to just do a factory reset. So basically start over fresh and start announcing carbs and continue to enter or, announce carbs the rest of the time that you're using it. However, this patient did not feel that she would be able to enter carbs before every meal and was not interested in doing that. So then, as Dr. Sharif mentioned, we can actually adjust the target range that we're going for. And it seems a little counterintuitive, but rather than looking for a higher target, we actually would recommend that she adjust to a lower target. And the reason for this is that we're hoping that as she's eating, the pump actually gets a little more aggressive on the front end, trying to keep her at a lower glucose level so that she doesn't have as significant of a rise as she's eating, followed by then a big bolus of insulin, or not bolus, but increased basal insulin that's going to drop her down too low. So it seems a little counterintuitive to go for a lower target, but in the, I guess, the algorithm of islet can be helpful to give more insulin up front. Additionally, too, just looking, so that's kind of a way to prevent the hypoglycemia, looking at ways to correct reasons for hyperglycemia, again, just avoiding overtreatment of the hypoglycemia. And then we're also now going to be doing this lower target to try to prevent it from going quite as high. And then patient education. So one thing that could talk with her about is adding more protein to her meals just to try to help stabilize her blood sugar and try to prevent as large of spikes with food. And then if she were to want to complete the factory reset, we would just want to remind her of all the education pearls for when a patient's newly starting on the islet, like eating the usual size meals during the initial phase and announcing all meals so that the algorithm can learn her routine. So then this is just 1 week later, just to see what happened. So she did go with that lower target. And so this, it looks like her hypoglycemia did improve. She was now down to about 1% hypoglycemia. And keep in mind that this is 1 week later and it's a 2-week AGP. So it is pulling into that time where she was having more hypoglycemia before she lowered her target. And she did report when we called her and checked in on things that she reported that things had drastically improved and she had not had any hypoglycemia since changing her target goal. All right, so then that was all for case number 2. So we'll jump into case number 3, which is Omnipod 5 and preset meals. So as Erin kind of alluded to at the end of her presentation, while carb counting is ideal and would be the best for working with the pump, sometimes patients are not able to carb count for a number of reasons. So this is a scenario where a patient couldn't carb count and how we use the Omnipod to try to meet her needs. So OP is a 63-year-old female with type 2 diabetes diagnosed in December of 2018, previously controlled with Janumet. She status post Whipple in August of 19. She started her first pump in November of 2020, and that was the Omnipod Dash system. She's unable to carb count, but does follow a pretty consistent meal plan. So to the right are her Omnipod Dash settings. So you can see her basal is roughly about 13.5 units per day. Her insulin, her carbohydrate insulin, she has a midnight carb ratio of 15, but she's not using that. Instead, she's using bolus presets in the PDM, which is for a glucose of 90 to 129 is 12 units, and then pretty much goes up by 1 unit from there for every 50 above 150. She also does take an additional 1 to 2 units if her glucose is greater than 182 hours after the meal. Sensitivity / correction is 50, and then her blood glucose target is 100 with an active insulin at 4 hours. So this is what her control looks like while she's on that Omnipod Dash settings or system with those settings. So she is ready to transition to the Omnipod 5 pump. So here again are her settings for a reminder. What are anyone's initial thoughts on how we can go about transitioning her from this Dash system to the Omnipod 5? What would you recommend her settings would be, knowing that the Omnipod 5 is a system that does require carb entry? Or how would you go about calculating, I guess, might be a better answer or question. All right, well, we can just kind of jump to the next slide. So the first thing to do would be to calculate her total daily dose of insulin, which is about 58 units. If we're going with the most conservative amount, or well, actually, I'm sorry, that is pulling from just her report of 58 units for her total daily dose. Using the rule of 450, using 450 divided by 58 units, it gets us to 7.7, which would be, a whole number would be 8 grams, so 1 unit for every 8 grams. Now, if we want to use the most conservative dosing to start with knowing that we can follow up and always make things more aggressive, we could just assume that she's using about 12 units of insulin with each of her meals, because that's where her scale started. She did report that she uses somewhere between 12 and 14 units typically with most of her meals. So taking 12 units times the 8 grams of carbohydrates would bring us to 96 grams that she could enter into the pump to get her 12 units of insulin. Similarly, we would calculate the correction factor with a roll of 1700, which gives us a correction of about 30. So here's kind of just a summary of the settings. So carrying her basal forward from what she was doing previously, the correction factor, the carb ratio of 8 and the correction factor of 30. Education that we provide to the patient is for her meals to just start by entering 96 grams of carbs for each meal. We could always, as we're talking with her and adjusting, consider having her do less for smaller meals and more for bigger meals if needed. And then also gave her some snack parameters. So to enter 16 grams, which would give her about 2 units of insulin for a small snack, and enter 24 grams or 3 units for a large snack. So then after doing this was at follow-up. So it looks like she did very, very well with these settings with a target range or time in range of 85. Does anything stand out for things that could even be further improved? And I can even go to her daily too, if that would be helpful. So overall, it looks like she is doing pretty well. Things that you might note is that she's using these 96 units pretty regularly, but sometimes she is increasing it to the 110. She's also giving herself these little correction doses sometimes, which these were her snack recommendations, the 16 and the 24. However, knowing that her history was to give herself about 2 units if her blood sugar was elevated 2 hours after a meal, it seems like it's following that pattern, so she might be doing a little bit of that. So she possibly could use a higher insulin to carb ratio, which we would just want to re-go through those calculations to try to increase the amount of insulin she's getting. So going through our plan, identify reasons for hypoglycemia, no concerns, identify and correct reasons for hyperglycemia. Again, trying to possibly increase that carb ratio or strengthen that carb ratio at lunch. If we're looking for roughly a 20% increase, that would be increasing her dose by about 2 units, which would calculate to an entry of 112 grams. And then patient education is just reminding her to use that use CGM button to give corrections rather than entering those fake carbs, if that's what that 2 hour after the meals where she was entering the 16 or the 24 grams would be. So then we'll move on to our final case, which is a case of tandem with control IQ and exercise mode. So TD is a 45-year-old male with type 1 diabetes, diagnosed at age 19. He's on the Medtronic 770G pump, his 770G pump is out of warranty and he's transitioning to the tandem with control IQ. He's overall happy with the pump and the Dexcom sensor, but he is frustrated with the amount of hypoglycemia he's having occur with activity. He lives a very active lifestyle and is frequently having hypoglycemia. He's manually suspending the pump a lot and consuming a lot of extra calories in order to keep up with his blood sugar to continue on with his home projects. So here is his pump report. As you see, he does have pretty good control, so 78% time in range. However, he's having about 2% hypoglycemia, which while that's, within kind of our goal of less than 4%, it's really bothersome for him and he's having to prevent it and, kind of act on it sooner. Okay, so looking at the daily report, there is a little bit of a key in the left-hand corner to help with kind of things that stand out. But what are you noticing? What's standing out to you about this pump report?
Is he getting a lot of extra auto boluses in there?
Yeah, he really is. And some of that might be due to he's also having the stop sign, the manual suspension. So he's on a bit of a roller coaster where his blood sugar starts dropping. He manually suspends the pump, turns on exercise mode, manually suspends it further, and then his blood sugar just rises a ton. So then he gets all these auto corrections to try to bring it down. And he's just kind of in this thing where he's chasing the highs and chasing the lows. So different education points to just kind of talk about before exercise is really having the patient hone in on like what the exercise does to their individual blood sugar. So focusing on things like the type, the intensity, the duration of exercise, time of day in relation to the meals, and try to figure out, you know, kind of get them to see if they can establish like a pattern for how that particular exercise may impact their blood sugar. Having them assess insulin on board prior to exercise, determining the target glucose range for an individual's risk of hypoglycemia, and then having them watch the trend arrows too to kind of predict going into exercise. Because he is a patient who's eating a lot of carbohydrates prior to exercise just to try to prevent himself from going too low. And, you know, paying attention to some of these routines might help him figure out if he should or should not be eating and what may happen to his blood sugar. So looking at exercise mode. So if he could turn on exercise mode and he could do that 1 to 2 hours in advance of his exercise. That will change his target to about 140 to 160 rather than the typical range of 112.5 to 160, and it will also cause glucose or insulin to suspend at a glucose of 80 rather than 70. And then for strenuous or prolonged exercise that are greater than 60 minutes, he could also consider having the exercise mode remain on for 12 hours after the exercise to prevent that kind of post-exercise hypoglycemia when insulin has been increased in the setting of exercise. So then adjusting insulin tandem using program basal settings. So we could consider reducing mealtime bolus insulin prior to exercise by 25 to 75%. Bolus dose reductions mean less insulin on board during exercise, lower bolus dose likely needed post-exercise when insulin action is increased. And then for basal settings, if the basal settings are used for an AID system, could consider decreasing basal rates all the way up to 80%. All right, so then as Erin highlighted, one of the really good big benefits of the tandem system is the ability to create 2 profiles. So for a person like this patient who knows that they're going to be really active during the day and kind of struggles with hypoglycemia all day long, we could consider creating a whole separate profile with some of those dose reductions already just in place that he could just switch to on days where he knows he's going to be really active. So I guess just any initial thoughts with his settings, what could we change? Basal, correction factor, carb ratio, where would you start?
Would you start by maybe decreasing the basal rate during the day?
Yeah, I think that's definitely something we could definitely do. So, you know, just something that is kind of, I'll kind of highlight this here, trial and error. So not really necessarily one right answer, but one thing that we could consider is just reducing the basal during the day by about 30 to 40% and see what happens. And we can always go back up if it's too much. Additionally, weaken the correction factor around the times that he's exercising and around the time and the carb ratio around the times that he's exercising as well. And even I think the box doesn't highlight it too, but we even reduced it at that 5 p.m. time, kind of following when exercise is, just knowing that the insulin activity has been increased in the setting of exercise. So again, trial and error. This, you know, more, this patient I think is still kind of in the trial period too, so more to come on results. And then plan, so kind of going through this just as a summary one more time. So identifying reasons for hypoglycemia. So either we can try an exercise activity, or for this patient who's exercising throughout the whole day, making an active insulin profile setting. Identifying and correcting reasons for hyperglycemia. So avoid prolonged pump suspensions if possible. And then patient education. So turn on the exercise activity about 60 to 120 minutes in advance of exercise. Avoid eating carbs before exercise if the glucose is not low before the activity, because then if you do, then the pump's going to kind of ramp up how much insulin it's going to give you because it's going to see the glucose rising, which then can actually lead to more hypoglycemia. Temporarily set low alert higher, so changing it from 70 to 100 so that, you know, if you are starting to fall low, you can catch it sooner and start eating before getting to true hypoglycemia. And then meal times, consider low carb / low glycemic food options and focus on protein, and then enter less carbs than eating or adjust bolus dose downward manually. So I think those were all the cases. Thank you so much. Any questions or other tidbits or thoughts before we close out? All right. Well, thank you all for joining tonight and for your participation. I hope everyone has a wonderful night.
Thank you.
Okay.
Thanks, Allison.
Thanks. Bye.